and taking time out of your day. This is something that I've been peddling around a little bit because I think it's definitely something of interest to me, ultrasound. But I've kind of, since leaving the hospital setting, I really kind of been motivated by this because when I was a trainee, I actually learned from a very senior physiotherapist in the UK, and he was like my mentor and guru in terms of ultrasound training. And I feel that since I'm no longer in the hospital setting, I can give back a little bit better now. And I think this is one of those areas where, as those of you working in sports or musculoskeletal medicine or physiotherapy and rehab, it's just one of those tools that is widely available now, and something that we should all be sort of taking up and using, not so that you can bill the patients more, but because you can use it for their rehab, and you can use it to give them really good feedback in terms of what they're doing, what they may not be doing right, and also, because you're often the first port of call for patients, okay? And if you can do that quick ultrasound, not necessarily a super detailed diagnostic ultrasound, but something that gives you an idea to say, oh, that Achilles doesn't look good. Oh, bugger, it looks like it's torn. Let's get it seen more urgently. I think it's very, very helpful. So that was my motivation for this. I've given a rendition of this talk to the SPA as well, Singapore Physiotherapy Association, and there was lots of enthusiasm from that. And I think they want to start formalizing some training as well. So hopefully, as kind of momentum grows, we can start to do something along those lines. Yeah. Just a quick show of hands. Does anyone have any experience of using ultrasound, musculoskeletal ultrasound? 1, 2, 3, 4. Okay. And what kind of setting was that in? Was it as you were training or in your clinical practice?
For me, it's recent, so I decided to invest in ultrasound. So for me, it's a recent venture. I invested in the Clarius L15. I thought it was a good point of difference and helpful diagnostically, but also for biofeedback. So it's something that's new for me, and I'm keen to explore a bit more. So.
Cool.
I just used it in the public system here in the hospital.
Okay.
That's where I got exposed to it. The sports doctor that
who was that?
Dr. Fazio.
Oh yeah, Fazio. Yeah. Okay. Yeah. Who else?
That's right, I can chat. Mostly in like a private practice setting when I was in London.
Okay.
Pre and postnatal clients, and especially with clinical Pilates, to encourage activation of the deep abdominal muscles and just giving a bit more feedback.
Okay, so you like pelvic floor,
yes,
and using the curved linear transducer and things like that.
Yeah.
Okay. Is there anybody else? All right. So let's move on. So conflicts of interest, many, but I just put it as none because it's just easier. So this is my first plug. Oh dear. I hope it comes out. Basically, I have a YouTube channel, and I put all these slides and everything on there, but I've broken it down into bite-sized chunks. It takes me ages to like edit the videos, but and I've taken a little bit of a hiatus this week because it was just getting overwhelming. But please have a look, please subscribe, please follow, like if you like, dislike if you don't like. And but it's all there, and it just goes through the basics of how to hold the transducer, how to adjust the controls, what to adjust, and everything like that. And those were all the things that Pete kind of took me through as he was kind of guiding me through MSK imaging. So yeah, so it's all there. There's 2 more plugs, and one is the book. I don't get any royalties from this, I'm afraid. Yeah, don't ever publish with anyway. But yeah, anyway, it's on injections, and that's kind of what I do a lot of. And but it also talks a little bit about imaging and how to position patients and so on. please. And then there's this last one, which is a free resource that I put together, I think during COVID, with some of the team from the hospital. And it just has lots and lots of conditions listed out and some basic information for patients, for clinicians, GPs, whoever. Yeah, it's just as a free resource. Okay, so first, let's talk a little bit about the background to ultrasound imaging. For most of us in musculoskeletal medicine, we don't use stethoscopes, but the ultrasound has become like the stethoscope for us, because when somebody comes in and they say, I've sprained my ankle or I've hurt my shoulder, after examining them, the next thing that I tend to do is scan them. Okay? And that's because the ultrasound provides lots and lots of information on what might be going on, and you can use it to correlate your clinical findings. Example is, I had a patient come in with shoulder impingement or some difficulty with kind of abduction, scanned their shoulder, expecting to find a nice tendinopathic tendon, found a small tear, full thickness, running through the supraspinatus. So, you know, it kind of, it marries up what you're finding clinically as well as what's actually going on. And it gives the patient some real-time evidence and actually gets them a little bit more buy-in from them in terms of when you're telling them about management, you get their sort of, you get them on board a little bit more easily. Quite often patients do wonder about the difference between the imaging and the therapy side of things. Of course, the therapy isn't for imaging purposes, but it has that lower frequency, it has that heating effect, and we all probably have them in clinic. But the main thing with the imaging is obviously the whole computer jiggery-pokery that goes on in the machine and the processing. And now, actually, although here I've got a very big machine, got a photo of a big machine, it's getting much more portable. And Matt, you said about the Clarius, there's GE, there's Philips, all the kind of big brands have their own portable machines. And over time, they're getting smaller and smaller. And now you can just plug it into your iPhone as well. So it's really, really useful to have in your back pocket. But the key component is the transducer. Okay? And having a quality transducer is really, really, really important. And understanding how to look after it also is very important. God knows I've cringed a few times when my trainees used to drop the transducer and go, oops. No, that's like $10,000, just like you busted there. But the key components is this area here. Okay, this is the piezoelectric crystals, and basically what happens is when you get an electrical signal over this piezoelectric crystals, it emits a sound wave into the tissue. Okay, when it emits a sound wave and it hits a structure, part of that gets reflected back, okay, to the piezoelectric crystals, which then creates another electrical signal, sends it up to the machine, and then you get the images and so on and so forth. Now, depending on the depth of that image, the returning signal will be stronger or weaker. So the more superficial structures will, if you have the same type of structure, let's say like a coin or something like that in something, you'll get the same type of image back, but it will be stronger from the ones that are more superficial than the ones that are deeper. And that's because as the sound waves are coming back, you get a degree of attenuation, so absorption of that sound wave through the tissue coming back. Okay. There's various other permutations to this. One of them being if you come across fluid. If you come across fluid, what tends to happen is that as the sound wave comes in, more of that signal gets transmitted. And as a consequence, the far end of that area of fluid will appear brighter. And that's a phenomenon called post-acoustic enhancement. And then finally, when you have air, air doesn't transmit the sound waves so well. And you're probably sitting there thinking, well, you know, I'm sitting here listening to you. Your voice is being transmitted in the air. How does that work out? But this is ultrasound waves. It's a much higher frequency, okay, higher energy. And for ultrasound waves to be transmitted, they need to be transmitted through a medium. So that's why we use the ultrasound gel for the transmission of those sound waves. And that's why when it goes into a pocket of air, everything appears blank. So for you guys are from heart and lung? Yes, I see your heart and lung. In heart and lung, or in emergency medicine or in heart and lung physiotherapy, if you're using the ultrasound, you're looking for that fluid level, right? Whereas in normal kind of lungs, everything appears black. When you have fluid there, it'll appear brighter, or there'll be some kind of change to the medium. So the next part is knowing the controls. Now, this machine here is what I used to use in the hospital. It's a GE Logic S7 XT Clear, which sounds really complicated, but actually it's just a GE machine. And the great thing about GE machines is that the interface, the layout, and everything is pretty much standard across the whole line. Not that I'm sponsored by GE or anything like that, it sounds like it. But that's what I love about GE machines. Other brands that you go to, over time they kind of transition to this way and that way, and actually it gets a little bit confusing. But there are some essential controls that you need to know when you're doing your scanning. First and foremost is selecting the correct probe. Right? And that may sound common sense, but the number of times I've, again, had trainees who've been scanning a particular area, and I say, hey, you know, maybe you should adjust it to a different probe because it has better function. So an example is here on the left, right? We're scanning my wrist joint, and this is using the curved transducer, which you may be using for pelvic scans, okay? And this is comparing it to the hockey stick. Now I know it doesn't project so well, but immediately, even with the poor projection, you can see that the bones aren't very visible here on the curvilinear transducer as compared to the hockey stick transducer. So choosing the transducer appropriate to the area that you're scanning is hugely important. The other thing is choosing the settings. Now most manufacturers will have optimized various settings according to the transducer that you're using. Okay. And again, I say this because sometimes I've come across my colleagues who've been scanning a shoulder on scrotal settings. And you know, you just sort of sit there waiting for them to realize it. And they're like, oh yeah, but I can't see the structure. I'm like, dude, like maybe just have a look at your settings again. It's like, oh, okay. So, you know, it's really, really important because you're just not going to get anything that's optimized. Okay. And if you can start off on a kind of good start from a good starting point, then anywhere above that, you know, it's going to be even better. One of the important things to think about is the focus. Okay. Now, when you're taking photographs, the aim is to sharpen that image, right? But in ultrasound scanning, what we're trying to do is we're trying to concentrate those sound waves on a particular area. In doing so, by concentrating the most sound waves in that area, you're going to get the most sound waves back. Okay. And if you don't change your focus, and let's say your structure is up here, and your focus is down here, you can imagine there's going to be a sparsity of sound waves coming back. Okay? And so your image isn't going to look so sharp, and actually evaluating that area is going to be much more difficult. Okay? So what I usually say is the focus needs to be slightly below the area that you're scanning. So let's say you're scanning the VI, for example. So you want to have the focus just over the bone, okay, over the femur, rather than at the level of that vastus. Yeah? If there's any questions, feel free. This is a super, I'm rushing through this because there's like 100 slides. The next thing, the depth. Okay, the way I see this is the field of view. All right. So your field of view needs to be appropriate for the area that you're scanning. Okay? If the structure that you're scanning is down here, but your field of view is only up to there, there's going to be two assumptions. One, that everything is normal, or two, they have huge anatomical issues. Okay? But if you can get the field of view appropriate, then you can start to adjust your other settings. So your focus, your frequency, and so on. Another one, your gain. Gain is basically like the aperture on a camera. Okay? So if the gain is very small or low, then the aperture is going to be very small and you're not going to get much sound waves back. If you increase the gain, the aperture gets bigger and you get lots and lots of sound waves back. But what's the issue with that? You get a lot more noise. Okay? So you have to find a balance between getting a sharp image and reducing and minimizing the amount of noise you get. Okay. This gain is called your overall gain. Okay. And that's just because you're just opening the aperture either from really, really small to really, really big, and that's it. Okay. There's further nuance later on where you can adjust it according to the depth, and I'll come on to that in a second. I'll come on to that in a second. And this is just an example of how adjusting the gain changes things. Okay, so this is, I think it was my quads. Yeah, don't laugh. It's not very personal. Anyway, so this is if you have the gain really high, okay, and if you reduce the gain, and if you reduce it further, it'll be darker and darker, and so on. But you can see, if you want to see the bone, you need to get that kind of sweet spot where you get enough signal from down the deeper structures, but you don't want to get so much signal that it blurs out the superficial structures. Yeah? So adjusting the overall gain is an important step when you're doing your scan. And all of these things you're kind of doing as you're going along. And it may be, even if you're scanning the same area, you change the orientation a little bit, or you adjust the transducer, then you need to adjust it. So it's really like fine-tuning as you go. Next, we have the frequency. Okay. Now, this probably sounds like a bit of a physics lesson, and it kind of is. But remember, you have to be able to adjust the frequency. So with lower frequency, we have better penetration of the tissue, but lower resolution. The reason we have the better penetration is because the sound waves are suddenly like much longer, okay, and they go into the tissue. But because there's fewer sound waves going in, the resolution is less. Okay. When we increase the frequency, because there's higher energy, the penetration goes down, but the resolution goes up because we're getting more sound waves. Does that make sense? So it's basically just an inverse relationship. I mean, if I took out the bit about the penetration, then it kind of makes more sense. So higher frequency, better resolution, lower frequency, poorer resolution, and the penetration is opposite. Finally, knowing where the freeze button, very, very important. Don't be fiddling around with looking for the freeze button. Okay? And this is where having a standardized layout is very useful. Quite often is the case where I've been using a GE machine for years, and then I sort of have a Philips machine or a Canon kind of thrust upon me, and I'm like, I don't know where the controls are. And so you'll often find me, if I go to OT, I just be staring at the machine for about 10 minutes, trying to work out where I make the adjustments from. Okay. So having familiarity with the machine is very, very important. So when you're optimizing your image, these are the things that you need to be adjusting. And it's a constant, micro adjustment as you're going along. There are some machines that do auto adjustments, and you just basically press one button and the machine tries to optimize it for you. But you have to remember that's based on their algorithms and everything. So it may not be appropriate to what you're trying to achieve. Yeah? And particularly if you're trying to do a like-for-like comparison, let's say, 6 weeks down the line, you're seeing the same structure, you might want to adjust everything. You can position the patient the same way so that the image is comparable to what you achieved previously. Yeah. So optimizing the image is really, really important. Then, as I talked about the transducer before, there's different types. The curved one has, the curvilinear is very useful for pelvic scans, for hip joints, for shoulder joints if you're kind of doing guided injections and so on. It's got a very wide range of view, wide field of view, and because the frequency is very low, so here 1 to 6 megahertz, it's got a much higher penetration. Yeah, so hence it's useful for the abdominal scans and the pelvic scans and so on. In contrast, the hockey stick is 8 to 18 megahertz, okay? So much higher frequency. And you can see the footprint here is much, much smaller than the curved one, okay? So this is really, really helpful for superficial structures, such as your wrist or your hand, maybe even the ankle ligaments as well, okay? Particularly areas where it's kind of difficult to maneuver the transducer. So you want like a really small transducer to kind of get into the nooks and crannies. Next, we have one of the linear transducers, and this is a higher frequency linear transducer. Okay. Now, there's some nuances to these things. Some of them have matrix, this, that, and the other thing. But essentially, what this is essentially good for things like shoulders, knees, maybe ankle joints as well. And it gives a high resolution, so 6 to 15 megahertz. A decent frequency, and it's a balance between frequency and penetration. And then lastly, we have a lower frequency linear transducer. So similar footprint, but maybe for patients who have a little bit more adiposity, maybe they can't quite get into the position that optimizes things, so you just need to scan in a slightly different way. So you have to adjust it according to the patient as well as the area that you're scanning. And again, coming back to my wrist, I think this is, yeah, wrist. So you can see the differences. So the curvilinear transducer, the standard linear transducer, and then the hockey stick. And with the hockey stick, you can if the image were a little bit clearer, you could almost see the fibers of the tendons going across as well. Holding the transducer, this is how not to hold the transducer. And I'm presuming that the guys who have been taught about ultrasound don't hold it that way because you can't control it. It's really, really hard to control. It's like kind of an open chain movement, basically. There's no control over that. The way I try and teach my trainees to do it was holding it like a pen. So like a pen grip, okay? And then you have it like a tripod. One of the most challenging things to teach medics or students is actually resting your hand on the patient. For you guys it's kind of easy, right? Because you guys are so accustomed to like examining patients, but medical students are like, whoa, what? I have to touch this patient? No, I just don't think I can. But putting your hand on the patient stabilizes it, and then you can follow the contour much more easily. If you aim to get a good image just by holding it like that, it's very, very hard to control, okay? Because there's the sound waves that are going to be bouncing all over the place. You're going to get anisotropy, the phenomenon where the imagery appears darker, okay? And it's just going to be much, much harder to control. So if you can follow that patient's anatomy with the palm of your hand, it's going to be much easier to get decent images. And it's basically like that. And it applies to all transducers. Okay? So whether it's the hockey stick, the linear, the curvilinear, if you can get used to doing it that way, your images will be much better. Okay? And it's just a matter of practice after time. there's a whole bunch of different machines available. I think I've probably used most of these at some stage. And it goes from, you know, the really high super duper ones that link to PAC systems and so on and so forth, to ones that are more portable, that you have limited sort of use for. Sorry, GE guys, the next image you're not going to be happy about. And then you have the portable ones, okay? Sorry, you should have thrown me the slide of your one, so I would put it in. But so you know, each of the portable systems have their own kind of pluses and minuses, and you've kind of got to work out what's right for you. You know, so the Clarius that you have has like the top and the bottom. It's got 2 different types of transducer. The Philips, you know, you have to have 3 different types of transducer if you're aiming to scan all different areas. The GE one, does it have the top and the bottom, like the Clarius, is it?
The G one.
It's your moment. The GE portable transducer has what? Like the curvilinear and the linear?
The curve and the linear.
Okay,
so
so
both sides.
both sides, right? So, you know, again, has a wide variety of different functions. So you just kind of got to work out which one's right for you and for what you're going to be doing. Patient factors, I mean, not much we can do about that, but these things all play a part. Okay, especially as patients get older, the quality of the tissue tends to not be so great, and when you're scanning, sometimes it's just really, really darn hard to get decent images. And I found that particularly when I still do, but when I do spine injections. So when you're trying to look for the facet joints, and when you're trying to look for the nerve, the spinous processes and so on, it's really, really quite challenging sometimes. Operator dependent, of course, you know, with time you get the practice. I would really recommend these guidelines. So, and they're free. That's really good. Free is good. It's the European Society of Radiology guidelines on MSK ultrasound scanning. Download it, make a little booklet out of it, keep it on your work desk, and refer to it when you're scanning. Really, really solid. And even now in the videos that I post online, I still use the images from that as a kind of baseline. So please do use them. Okay, so that's like a whole weekend crash condensed into about 30 minutes of me talking. But that's the basic mechanics of ultrasound. There's a lot more to it if you want to spend time doing it, and please feel free to drop us a message, and I'm more than happy to walk you through the machine that I have in clinic a little bit more, in a bit more detail, but that's the nuggets of it. So let's have a think about how we can use it for rehab. And I guess the question is, what is rehab at the end of the day? Everyone has slightly different opinions of it. Some patients, when I say, "Oh, have you been for any rehab?" Yeah, I just lied there. And then I say, "So what happened then?" And then, I had something done to my knee. And I was like, "Okay, but that's not really, by definition, you doing some active rehab. That's just you lying down." So to me, it's this. Okay, the journey of the patient to return to health after any of those 3: injury, illness, or immobilization, and has led to a functional loss. And to me, that's the key. Getting that functional element back as well is very, very important. So where does ultrasound fit in? Well, ultrasound has been used in physiotherapy for a long, long time. I mean, this is back from 2005. I understand that Paul Hodges, I didn't know this, but somebody said that he's a bit of a guru in rehab. Is that correct? Yeah. Okay. Sorry. Forgive my naivety in this, but and in this he basically says that actually it's you can use it. Yeah. There is no reason that we shouldn't be using it. It's just in different places the practice varies. Again, apparently there's a few gurus in this. Maria Stokes, is that right? Yeah. Yeah, anyway, there's a few kind of big names in this, apparently. And there's this consensus statement, which I found very interesting, because it was from a kind of clinical education perspective. And they were saying that what is the scope of using ultrasound? And you can use it for diagnostic purposes. So are you monitoring, or are you corroborating your clinical findings with ultrasound findings? Can you use it for rehab? And certainly you can. Can you use it for interventional? Maybe a little bit tricky for us here. Okay. But certainly if you're using it for research purposes as well, and a lot of people are using ultrasound in research as well. Not just people in musculoskeletal medicine, but dietitians and different kind of groups of people that are using ultrasound as well. Learning journey looks very scary, but to be fair, I mean, if you've been through any sort of physiotherapy, medicine, undergraduate program, these are the kind of things that they put in. And actually it's very, very straightforward. Just understanding about the system, understanding why you're doing it, and learning how to use it. That's basically the essence of it. So in terms of investigations, in terms of rehabilitation, there's kind of 4 areas that I think it can be used. First and foremost is the investigation. So if we take the knee, for example, okay, the areas that we can scan in the knee are multiple. You can have an idea of the muscles, of course. You can see if there's any obvious muscle tears. You can assess the tendon, the quality of the tendon. Okay? So recently I had an athlete come in and they had issues with their tibialis posterior. They'd been running on it and they were just having ongoing pain in the tib post. When you look at it, you can see there's a split tear running all the way through the tib post. Okay? Now, you can get an MRI scan if you want, but actually you can identify that quite easily on the ultrasound as well. So you can tell a lot of information, especially about the tendons. The joint is a little bit tricky to assess, okay, because the ultrasound waves don't penetrate into the joint. But you can have an idea of what's going on in the joint. Let's say the knee again. So if somebody comes in and you have a concern about, say, degenerative meniscus or something, you might find that there's a bulging meniscus on the coming out of the joint. Now you can't see into it any further, but you can have an idea that you can say, oops, there's something going on there. Maybe this needs further assessment. Okay. In patients with degenerative joint disease, there'll be certain findings that you see as well. So you'll see the osteophytes, you may see the Baker's cyst, you may see the joint effusions, and this is all kind of bits of information coming in to tell you how bad this degenerative joint disease may be. Yeah. So it's all part. It's not the be-all and end-all for everything, but it's very, very useful in your clinical practice. So this is just an example of some ultrasounds. So this is the quadriceps tendon here, quadriceps muscle. Okay, this is in long axis, this is in short axis, and here, this is the rectus femoris. So if, let's say, for argument's sake, you have a concern about a rect fem tear, okay, you can quite easily see it on the ultrasound. Yeah? And then you can shift into long axis and see if the muscle fibers are still in one particular orientation, if they're maintaining their pronation angle, fascicle length, and so on. So you can make all these measurements and assessments of the muscle. If we go on to the tendons, so this is an example of a patellar tendon. And here we have again in short axis, and here we have in long axis. So again, you can see the architecture of the tendon. You can see if there's any tendinopathy. You can see if there's any tears. You can see if it's in place, or maybe, let's say for example, a biceps tendon of the shoulder, whether it's subluxus, or a wrist tendon, does it sublux as well? Yeah. So you can see the normal movements. And the beauty of it is you can also reposition your patient in different ways and assess that tendon. So let's say, for example, an Achilles tendon rupture. Okay. If you send them for an MRI scan, all you can do is have a static image, and that's it, right? And nothing further. when you're assessing the Achilles with the ultrasound, you can squeeze the calf, you can dorsiflex, you can plantarflex, you can move it this way, and you can see whether the gap shifts. Okay? So you get a lot more functional and a lot more pragmatic information that you can use in your clinical practice. Ligaments. I mean, if I probably scanned half of you here, probably there'd be issues with ankle ligaments, right? Okay. But again, you don't need MR scans always to have an impression of what's going on with the ATFL, CFL, and so on. Okay. I mean, if you're considering something further, say interventions, surgeries, and so on, yes, you may require that at that stage. But for initial phase of treatment and rehab, ultrasound's more than adequate. Do you see the ATFL? No, sorry, I forgot to mark that. And then lastly, nerves. So nerves, again, this is the carpal tunnel. Here we have here, I don't know if you can appreciate it on the screen, but that's the median nerve there. Okay. Here we have the flexor retinaculum running over the top, and we have the flexor tendons underneath. So if you want to have an assessment of these areas, particularly superficial areas, you don't really need MR scans, CTs, all those things. You can do a lot with ultrasound. Like I said, the bones and joints are somewhat more challenging, but there have been instances where I picked up stress fractures on ultrasound. You can see the cortical changes on a stress fracture, and then you can move on to your other investigations. So even with bones and joints, even though you don't get the full kind of impression of what's going on, you'll get a kind of hint as to where you need to go further. And so I kind of try to summarize and see what are the things that you can do, and you can do all these things. And so as an investigation tool that you can have in the clinic, it's fairly comprehensive, right? And then after that, you can branch off and do the other investigations and the treatments and everything that you require. Yeah, that's just an example of a muscle tear that we saw, that I saw in clinic. And so, somebody comes in and they've got a tensor heart. You can see there's that big hematoma sitting between the gastroc and the ciliates. And imagine you're treating this conservatively. You're not sticking a needle in and draining it. You can just track this over time. So each week or every fortnight that they come in, you just progressively see the area consolidating. You can see the gap lessening, and then you can see it healing. Yeah, and that just helps you in terms of managing that patient. Tendon tears. I think I'll skip over this. This is just my dummy's guide on how to classify tendon tears. But you can also see lots and lots of tendon injury. So this is Achilles tendon tear here. Okay, and then if you can change the position of the foot, so you dorsiflex or you plantarflex, you try and open up that space, and then you can take measurements and you can say, well, actually, even if you plantarflex and the tendon doesn't really oppose so well, does that at that point require surgical treatment? You can make those kind of decisions based on what you're seeing on the ultrasound. This is an example of a MCL injury. So for any of you who do have a look at the YouTube channel, I had a really, really cracking MCL case. This patient had pain for like 3 or 4 months, and when you looked at his deep MCL, it was super thickened, and actually it was so well defined that you could differentiate between the superficial and the deep MCL, and you can see his meniscus popping out as well. So you get lots and lots of information. A nerve injury. So this is an example of a nerve transection. So something's gone straight through this nerve and it's transected it. Okay, so there's a gap. So the moment you see that, there should be a few alarm bells going. You should be saying, oops, I think this requires further investigation. Other things that you can see, effusions, things like myositis ossificans. So, you might be doing shockwave therapy for myositis ossificans, and you can see how things progress. Tendinopathies, stress fractures. Let's say you start doing shockwave for stress fractures. That's a proven treatment tool for it. Okay. Can you see how it progresses on the ultrasound as well? Can you see that periosteal reaction settling down, and then the bone sort of healing over and forming? So additional benefits, you can track the progress. The key thing is that it's non-irradiating, it's low cost, and it's repeatable, as long as you use the same parameters that you did. So what about the other areas? So functional training. I don't think I have time to go quite through this paper, but the essence is that they did the study looking at muscle activation and so on and so forth. And if you want the reference, I'll send it to you later on. And they looked at EMG, ultrasound, and force plate. And basically, they found a good correlation between all three of these measures. Okay, and what they wanted to know is, can you train patients to think in that way? And what they found was that actually you can, but it requires a bit more training. So you need to have the patient understand what a maximum contraction is, and then you can start to see at smaller percentage of contraction what the changes are on the ultrasound, and then you can give them that visual feedback as well. So there's ways around it, and I don't think I think there's ways of perfecting it according to the population that you're seeing and according to what type of injuries that you're seeing as well. And then lastly, monitoring progress. This is just a little paper that I got one of my students to write up some years ago, and this patient came in with a patellar tendon tear. I can't remember if he was on a bus or he was walking up the stairs, and he fell down, whacked his knee against the stairs, and then he came in with this whacking great big hole in his patellar tendon. Did anyone spot the hole? You can see, right? Yeah. And so when you scan it, you can see there's lots of increased vascularity, and then so this guy didn't want PRPs, he didn't want surgeries, and because it was a partial tear, the surgeon was also saying, well, we don't need to go in and do something unnecessarily. And so just over the course of a few weeks, we just monitored it. And then each time he came in, he had an ultrasound scan, and you can see by the 4th week how it's coming together beautifully, that it's organizing, and then by the 8th week, you can see it almost looks like a happy, healthy tendon. Okay, it looks thickened up, but it still looks better than it was 8 weeks prior. Okay. And just by taking those images, you can give that patient that reassurance that they're doing stuff the right way and it is healing. Achilles tendinopathy, again, patients who you may be doing shockwave therapy for, and you want to see if things are getting better. Okay, you can track their progress in terms of the treatment, and so it's very, very useful for all these kind of issues. Okay, so this is the last bit, the interventions. Now, I'm not sure how far we can go with this here, okay, in terms of all the kind of regulation and so on. But if any of you are planning on popping overseas, say to Oz or to the UK or to the US, have a crack at all of these as well. So because it's done. Okay. So these are all the types of interventions that you can do, and most things are a mixture of all. So you can go for the good old steroid. Depending on what you have available locally, you might have triamcinolone, Dexa, hydrocortisone, and the purpose of the steroid injection is twofold. So I tend to use the steroid, the triamcinolone, for joints. The dexamethasone is used for spine injections. Okay, and the reason being is because the dexamethasone is a solution and it doesn't go and sit on the blood vessels, and it doesn't cause vasospasm. And if you can imagine you're doing an injection around the neck nerves, you don't want vasospasm. Otherwise they come in with a bigger problem. But there's two ways of doing injections. You can do low volume or high volume. The high volume ones are really there to strip away adhesions. Okay, so somebody who's had a chronic tendinopathy or they've had like a chronic bursitis for a long, long time, that bursa will be super thick and super tight. And as a consequence, you know, whatever you're going to do in terms of rehab is going to be much more challenging. Hyaluronic acids, you know, part and parcel of what a lot of us do. Okay, so very, very useful for pain and cushioning in joints. I'll skip through some of these. The essential thing is, the higher the molecular weight, the better the cushioning. That's all you need. Okay, and it works by getting lots of water around the molecule and creating a cushion. Some people tend to combine it with PRP, so that PRP has that healing element, and the hyaluronic acid has the cushioning element. Starts to get a little bit expensive when you do both, and sometimes you don't know which one's the most effective part. And so I tend to stick to one and the other unless the patient specifically requests. PRP, everybody loves PRP, and actually it's great. I think it's kind of what we're allowed to do here in Singapore, and it's up to the point where it's very difficult to do all the regenerative stuff here in Singapore because it's not really allowed. In the US and places, they're doing things like taking the fat cells and spitting it down and injecting that into joints. They've been doing things with stem cells and so on. But here, the closest we can get to is with PRP. Okay. There's various systems that you have available. Here in Singapore, it's approved for tendons and ligaments, but there's lots and lots of evidence from overseas that it can be used for joints. So actually, really high quality evidence for things like knee OA. Okay? So in patients who've got chondromalacia or mild to moderate OA of the knee, PRP works wonders and it helps really well with pain. Okay. So much so that ESCA, I don't know if any of you know about ESCA, but the European Society for something knee arthroscopy, surgeons. And basically, they said that for patients with mild to moderate knee OA, it's good evidence. For patients with severe knee OA, hey, the evidence is not so great, but it's not going to do any harm. Okay. And actually, before I left the public hospital, I think last year I'd done nearly 100 or 120 patients with knee OA PRP injections, and the results were really, really good. I think the last time I actually did a hyaluronic acid injection was probably the year prior to that. So, you know, people are preferring that much more than other injections. Then, what else is there to say? Oh, prolotherapy. So prolotherapy, again, quite safe. It's you're trying. I tend to use this for ligaments. Okay, so you can use it for ankle ligaments. Okay, especially in those patients who have lots of chronic instability that you're just not able to overcome with stability exercises and proprioceptive exercises. So if you just really want to stiffen up ligaments, very, very useful. Some people have used it for things like back pains and all sorts of kind of pelvic pains and so on. I haven't quite ventured into that, and I'd be somewhat cautious in advising you to do so. But if it's a good old, MCL or ATFL or something like that, give it a crack, and it works really well. I think it's somewhat analogous to dry needling as well. So when you're just whacking the ligament, trying to promote bleeding. But when you add in the glucose or whatever the substrate that you add in, you're trying to create a further inflammatory process and get all the fibroblasts to come in and lay down all the collagen and really kind of stiffen that area. Okay, I think we don't have time to go through that. Then, good old local anesthetic. Yeah, very, very helpful. Just if you have someone who's got pain all over and you're just wondering where this pain is coming from, just poke them lots and lots of times with local anesthetic and then see which reduces their pain. Yeah, and then hopefully you get one and you're like, that's where your pain's coming from. And then the high volume, like I said, very useful for areas where there's adhesions. This is just a kind of summary page of all the different types. So it's really just useful to have an idea of what's going on and why you're doing it. And I think it's very important to understand, when even if you send your patients to surgeons or whoever, and they say, oh, this patient's going to come in and have this done. And you're like, why is that? And then having just a summary of why patients, because often patients don't have that explanation why you're doing something. Okay, and having it clear in your head is very useful when you're talking to the patient. The last thing is something called tenets, and this is something that came from the Mayo Clinic. It's basically shockwave, but in the tendon. Sounds very exciting, and it kind of is. But it sounds terrible as well. I don't know if you will all hear this. Actually, I lied to you guys yesterday. I do have an audio. Okay. Can you hear that? Maybe people at the back. It sounds like a saw. Okay. And basically, what you're doing is you're putting this needle into the tendon, or this is the plantar fascia, and you're trying to suck out that grotty tissue. Okay. It sounds terrible, right? But honestly, for tendons and these kind of things, I think it's the best thing since sliced bread, because it's minimally invasive. Okay, one needle goes in, take out all that nasty tissue, even calcific things. You can suck it all out. Patient basically is awake, so there's no GA risk. Okay, there's very little chance that you're going to cause any ruptures, and it's like, oops, oh, that wasn't meant to happen. Type thing. And then lastly, the outcomes from this are great. Okay, the actual research, the first kind of study was done by Joyce Coe at SGH, and they did it for patients with really, really bad tennis elbow. And what they found was that not only did pain improve, but function improved as well. And then when they did a follow-up over the course of 3 years, so this is at the very beginning, grotty looking tendon, lots of hyperechogenic areas. But this tendon actually looked like a healthy tendon. Okay, yes, it took a while. But after you take that nasty bit of tissue out, then the tendon has a chance to heal. And it can be used for lots of different areas. So jumper's knee, patellar tendons, calcific shoulder, rotator cuff issues, and so on. And so, to me, that's the kind of things that I would suggest for tendinopathy. Okay. And this is certainly something that maybe in the future, let's say maybe not here, let's say, but if you go overseas, maybe something that you can look into. Okay. That's it, I'm done. If you have any ideas for future topics, let me know. Or if you have any feedback, or if you just want to come in and just have a look at my machine, that's perfectly fine. Okay, any questions? Or is everyone super tired? Please have some food as well. Yeah, I hear the chocolate cakes.
To ultrasound scan for there's a lecture and we asked the lecturer will say, okay, you can use your ultrasound therapy machine that we usually use that in our physical therapy practices to screen factor. But there's another noting point from the lecturer that say, oh, that might cause pain provocation.
The heating effect of the ultrasound.
Probably the resonance that you can feel from that.
Yeah.
So will it happen when it comes to diagnostic ultrasound?
Oh no, not at all. Because it's much higher frequency. There is a concern, and you have to put it down when you're doing research projects that when using ultrasound there's a concern of harm to the patient, right? And actually, ultrasound imaging machines won't cause any heating effect. effect. I mean, in theory it can, but I've never seen that happen. The main thing is the pain that you cause to the patients because you're pushing too hard. Yeah, you're not going to have any issues with ultrasound. I think for all of those of you who are working with sports teams, very, very useful skill to have as well. Particularly if you're going overseas or with a dance company or if in rehab, correct? Like if you're getting neuro rehab going on. So very, very helpful.
Yes, one question. What's your take on the treatment for brass weakness there?
Okay.
It's not rupture, just
Yeah. So
PRP or
okay. So I think it depends on a couple of things. It depends on the size of the tear. Okay. If it's still amenable to a PRP injection, yeah, I think it's a good idea. I've had 3 patients recently with full thickness supraspinatus tear, and I've been doing the PRP for them, but I've done a kind of adapted form of it, so like an activated form of the PRP. So the trouble with PRP is it's a fluid, right? So if you inject it into a particular area, it's just going to flow around. The idea of the activated one is that you make it a bit more jelly-like, and so it sticks into that place. The first patient I did was about just before New Year, and I saw him about 5 or 6 days ago, and he was doing really well. I've had like another over the last weekend, so I'll wait and see how they do. But PRP still works very well. Yeah. I think again it depends on the case-by-case basis. For me, after the injection as well, you need to immobilize for a period of time, but they can do stuff below shoulder height and just do heavy lifting. Yeah. We good? Everyone happy? Fantastic. Thank you. Okay, why don't we all tuck in? I think they brought some rice as well.